on mental health programs and best practices. This morning, I will be moderating this session. I am a governor's office staff person. And today we have two ladies with us. I will read their introductions, their bios, but you can also find those bios on the agenda. There's a link to each bio on the agenda. So first, we have from the Bridge Center for Hope, Charlotte Claiborne. Charlotte Claiborne is the executive director for the Bridge Center for Hope. The Bridge Center Board of Directors selected Charlotte in September 2019 to oversee and manage all professional contracts, including RI internationals. Her educational attributes include 2 MBAs in management and healthcare management and a bachelor's in psychology. As the executive director, she will implement the Bridge Center's goals to provide a safety net to catch people in crisis, keep them out of the emergency rooms and jails, and link them to providers to create a continuum of care. Charlotte believes that mental health doesn't discriminate, nor does it have a respect of person, and affects everyone, and no one is immune. Welcome, Ms. Charlotte Claiborne. And second, we have Ms. Lysha Best. Lysha is the Louisiana State Director for RI International, presently overseeing all program services at the Bridge Center for Hope. Lysha joined RI International in December of 2015, serving in various leadership capacities at the Recovery Response Center in Durham, North Carolina. As a licensed clinician, Lysha has been able to provide services for individuals struggling with mental health and substance abuse issues. Lysha's passion has always been to help individuals in need and provide services to those in underserved populations. Lysha earned her master's in mental health counseling from North Carolina Central University and master's in business administration, healthcare management from University of North Carolina at Wilmington. So welcome, ladies. Thank you so much for agreeing to participate in this conference. I'm really excited to hear about this program because I've been hearing a lot about it in the community. So I look forward to the presentation. Without further ado, we'll turn it over to you.
Well, thank you first for having us. We appreciate you taking the time to reach out to us for us to be able to spread the word about what the Bridge Center for Hope is, the service and the programs that we provide in the community.
Absolutely. So I think I'm going to get started here on the presentation. And so we're going to show a short video. And in this video, it's going to talk about the Crisis Now model, which is the SAMHSA's national guidelines for best practice in crisis care. So we'll watch the video for a short time, and then I'll go through what the Crisis Now model actually is.
Medical system built to respond immediately to your crisis. Now rewind. It's been a bad day, but this time it's due to a mental health crisis, like thoughts of suicide. The same emergency medical system that responds to chest pain also responds to this type of crisis and is less than ideal to handle it. Yet it is this system that responds to thousands of people in a mental health crisis every day. In general, everyone in a mental health crisis gets routed through an emergency department. There, a person in crisis often waits between 18 hours and 3 days for connection to mental health care. This approach is difficult for patients and wastes a lot of resources. But the Crisis Now model outlines a tested and proven alternative, a way to improve crisis systems across the country by expanding the options for those of us in a crisis, while reducing overall healthcare costs by creating a true emergency crisis service. And there are big savings in the justice system too, while dramatically improving the experience of the person and their family members. Drawn from current national best practices in crisis response, Crisis Now focuses on 3 components that help ensure an appropriate level of care to anyone in crisis. Component 1, a crisis call center staffed by specialists that coordinate all levels of crisis care. They evaluate the current crisis and can support and stabilize up to 90% of the cases they get. Those that need more, get more, with these hubs dispatching appropriate resources and then supporting those resources and finding the best solutions. Component 2, 24/7 mobile crisis teams that work in the streets, meeting people where they are, and for the majority, resolving their crisis right then. Dispatched by the call center hub, they lessen the burden on local police and reduce the stigma that some feel when a uniformed officer knocks on their door. Component 3, crisis stabilization locations, which constitute the retreat model, can offer short-term care for people who need support and observation, regardless of their level of crisis. These programs operate 24/7 and are the right door to everyone in a mental health crisis, including those that may require involuntary treatment. These high-tech, high-touch facilities divert away from the emergency departments and jails while providing immediate specialized treatment. Police no longer need to decide between EDs or jail. The no wrong door approach reduces the time needed to handle these cases from hours to minutes and allows police to go back to supporting public safety, a role they're uniquely trained to do. Let's review the impact of the Crisis Now model in Maricopa County, Arizona, fourth most populous county in the US. In 2017, Maricopa County Police connected more than 23,000 people in a behavioral health crisis directly to crisis care. And those people were accepted 100% of the time. The Crisis Now initiatives saved the time equivalent of 37 full-time officers, reducing wait times in emergency departments for behavioral health patients by a total of 45 years, saving local hospitals and emergency departments a total of $37 million in avoided costs and losses, freeing them up to help the patients they're designed to treat, while routing behavioral health patients to a course of care that's best suited to their needs, and reducing Maricopa County's overall healthcare costs by an estimated $260 million, more than twice the cost of Crisis Now services. To learn more about how Crisis Now can make a difference in your community, go to crisisnow.com and download our white paper.
Okay, so that video was about the Crisis Now model. And so the Crisis Now model is really figuring out how we can best provide crisis services in your communities. As of right now, this is the current flow of, go back, Charlotte. Sorry. As of right now, this is the current flow that happens when someone is in crisis. So when someone's in crisis, they either engage, most times they engage with the police or law enforcement of some sort. And then they go to a hospital setting. And within that hospital setting or jail or prison is really not set up to deal with individuals in crisis. So they end up either being declined of services or referred somewhere else, or they end up just leaving the hospital against medical advice and not really receiving any type of services for the needs that they actually came in there for. Go ahead, Charlotte. So the Crisis Now model really focuses on a different route that we can go. So instead of sending individuals to hospitals or jail, we really want to focus on a pathway that is beneficial for the individual in crisis. So if they do come in contact with law enforcement, they would go to either go through a mobile crisis unit, meaning that individuals will go out into the community and meet with them and try to stabilize the crisis there, or they would come straight to a crisis facility, which we'll talk about a little bit throughout our presentation, which is the facility, the Bridge Center for Hope here in Baton Rouge, Louisiana. Go ahead. So the Crisis Now model really focuses on three components. So the first one is a crisis call center hub. And within that call center hub, individuals are able to call a general number that they're able to receive some type of services, and they'll able to navigate that crisis on the phone call. If they can't do that, then they will move to the next step, which would be the crisis mobile teams. These individuals will be dispatched from a call center, and they will go out to meet that individual where they are, try to navigate that crisis in the community. But if they can't, they would then bring them to a crisis receiving center, which, like I said, is here in East Baton Rouge Parish. So the crisis recovery, so our campus of connection model is what we call it. So it's really about focusing on all the services that we can put into one place. So here at this facility in East Baton Rouge Parish, we have our 23-hour observation unit. So individuals can come in, get assessed by nurse practitioners. They get psychiatric evaluations, nursing assessments and such. And then we also have our short-term crisis beds, which we call our living room model. We have a respite unit. We also coordinate with the pharmacy to make sure that we get medications here. We have a care management team. And then we also make sure that we coordinate with outpatient services to, when they discharge, that they have good appointments. Also at the campus of Connection, our facility, we really focus on peer powered. So a certified peer support specialist is someone who has lived experience. Either they've gone through some type of mental health challenge in the past or substance use challenge in the past. And they've kind of gotten to a point where they can talk about their story. So we really focus on those individuals. So we call it peer first, peer last. So that means that when an individual comes into our facility, they're met by a peer. So they talk to them and connect with them about what the issues are in the community or what they've gone through. And then before they leave the facility, they also talk with a peer. So that's why we try to make sure that we do peer first, peer last, so we can really treat individuals with empathic understanding and really connect with them. Also, our facility, we do direct law enforcement drop-offs. So individuals that come to this facility, they don't have to have medical clearance. So they don't have to go to a hospital first before they come to our facility. We're really focused on making sure that the facility is open for law enforcement officers and first responders to drop individuals off very easily. And then lastly, we're really focused on whole health. So really integrating mental health and substance use when they come into our facility. Keep clicking through for me. So just to sum it up about the Crisis Now model. So as we saw in the video, Crisis Now really focuses on a different model that we typically did in the past. And so with the Crisis Now model, you can see that it's 6 times better a clinical fit for the individual that's in crisis. And then also, since we are so accessible to law enforcement officers, it saves the time of about 37 full-time law enforcement officers, 37 law enforcement officers' time, because we actually quote a drop-off time of about 5 to 7 minutes, opposed to the 3 to 4 hours that it takes for them to drop someone off at the hospital or at jail. Also, it saves the time of about 45 years in hospital waiting areas, because when an individual goes to a hospital setting to receive crisis care or mental health care, they're there for about 18 hours before they get to see someone. Go ahead and click through. With this service, with the Crisis Now model, you're actually able to, they found that you're able to save about they're able to save about $260 million in mental health services, in how much it costs to provide this care. And then also $37 million in avoided costs at the hospital. So all these numbers come out of Maricopa County, which our facility, RI International, that's our first facility. And so all these numbers come out of Maricopa County, where they've seen at least 23,000 people dropped off from law enforcement officers. All righty. So now that I talked about Crisis Now, and now I'm going to get into talking about RI International as a company. So very generally, RI International, we're a international behavioral health company. And so we've been around for about 30 years providing mental health and substance use services. So we tend to think that we are the subject matter experts in crisis care. And so we take a lot of, Charlotte, click through for me. We take a lot of our practices from Walt Disney, and Walt Disney said very well that whatever you do it well. So we try to make sure that we're able to provide good care at all times, because we want people to come back to us when they receive good care. Click through. All right, so where can crisis go from here? So what you'll hear throughout my presentation is about, at the facility, we focus on recovery care. And then we also have this model called no wrong door. So no wrong door approach just means that we don't turn individuals away. If someone's in crisis, they should not have to try to figure out where they should go to receive care. So if an individual presents to our facility No matter what that is, they would not be turned away at the door. They would be greeted, and then we would try to figure out what the crisis is and how best we can help them. So the RI way. So the RI way, we focus on 4 components. So we focus on peer power, performance, engagement, and safety. Go ahead, Charlotte. All right. So peer powered. So peer power just means that, like I said, we use certified peer support specialists. So about 50% or 55% of our entire company is an identified peer. So we really focus on that engagement aspect and utilizing certified peer support specialists. We have a living room model. So a living room model really means that when you see the pictures, you'll see that our facility is very open and welcoming. We don't put barriers between ourselves, the staff, and the guests. We do call the individuals that come into our facility guests and not patients or clients, because we do like to feel like they're at home with us, and we want to make sure that we're able to create a very open and welcoming environment. And then we also use a no force first model. So that really means that we really focus on engagement and really trying to figure out how best to help that individual, because we don't like to use seclusion or restraint. Although we don't like to use it because that means that is a fail on our part if we do have to use that. So we try our best to use no force first and use our talking skills, engagement skills, and our peer support specialists to meet that individual where they are. Go ahead and click through for me. So another aspect of peer power practices just means that we're in collaboration. So we do with you and not to you. So whatever plan that the individual comes in with, we try to work with them on figuring out what's the best course of action. So coming up with their treatment plans and crisis plans and all those kinds of things, we work with them and we don't come up with the plan for them. So it's strengths focused. We always make sure that we talk to them about what are some things that you're good at? What are some things that you want to continue to grow? A lot of people that come into the facility, they do not really, sometimes they don't know what their strengths are. So we try to make sure that we focus on that and help them get to that point. We work on whole person wellness. And so when an individual come in, we don't just help them with substance use. We also talk to them about their mental health or vice versa. And then when they discharge, we also make sure that they have a primary care appointment because we want to make sure that they're able to focus on their whole health. Trauma-informed care, as we all know, trauma is very prevalent in this community, and we want to make sure that we're able to address those needs when we need to. And then once again, our no force first model. All right, so our performance aspects of the RI way, as I spoke about a little bit earlier, is our no wrong door policy. So why does no wrong door matter? So it really, like I said, it really means that if a person's in crisis, they get to come into our facility and figure out what that crisis is. We don't turn them away, and it really doesn't matter. Although this facility is for East Baton Rouge Parish, we try our best to make sure that it's accessible to anybody that's in crisis. So even if they're from a different parish, if they come to this facility, we would accept them, try to figure out what the crisis is, and then we would get them back to their parish of residence. We always find ways to say yes. So no matter what the situation is, we would find a way to say yes. We don't want to say no to individuals because once you start putting barriers in place, people decide not to come to treatment. We manage what they call quote unquote medical clearance. So like I said, most facilities, they want someone to go to a hospital first to receive medical clearance. That's not what we do here. We typically do a triage, and we have a triage process just to make sure that the individual is safe enough to be at the facility, but we don't require an individual to go to the hospital before they're able to come to us. We manage substance use disorders because we have a detox unit here at the facility, which we'll talk a little bit more about in a little while. Good. And then we manage high acuity. So individuals, like I said, at least half of the individuals that come to our facility come via law enforcement. So we really don't know who's going to be coming. So all the staff here are trained to manage high acuity individuals. And we try our best to address those needs when they come in. And I think we are all trying to do our part in fighting the stigma about mental health and substance use. So we want to make sure that, that the facility is accessible to anyone that may be struggling with mental health or substance use. You can click through. Go ahead and click again. All right, so another aspect of our RIA is engagement. So like I spoke about earlier, so we try our best to engage with the individuals as soon as they come through the door. So we engage with our guests, we engage with our community. So Charlotte and I, we go out into the community and have these conversations, make sure we're providing education to the community so everyone knows that our facility is open for individuals to receive care. And the last aspect of our RIA is safety. So when individuals come in, we do lots of screening and assessments. We screen for suicide ideations, homicidal ideations. We also do treatment planning. We collaborate with the individual. And then we also make sure that they have appropriate discharge plans when they leave. So this is, as I was talking about, this is one of our facilities in California. And so it's very open. We want to make sure that our facility is warm and welcoming, and we don't put any barriers between us and the individual receiving services, so they understand that we're there to help them. So these pictures are just pictures of our few facilities that we have across the country. Right now, we have about 14 facilities across 9 states, New Zealand, and Australia. So like I said, we've been providing this care for a while, and we're really excited about the facility here in Baton Rouge, which Charlotte is getting ready to talk about.
Quick question. Did you guys want to address questions now? We have a couple of questions from some attendees.
We do have a section at the end that has question and answer, so we may answer their questions as we go through the presentation.
Okay, we can wait on it.
Okay, so this is the Bridge Center for Hope facility here in East Baton Rouge Parish. This is just the front portion of the building. But what I wanted to do is kind of go back. What Lysha was giving you the best practices, and the reason why we went with the best practices first is because that was one of the reasons why we chose RI International as the service provider for the Bridge Center for Hope. But what I've also like to do when we educate people on mental health services and substance use, we have to also go back to the beginning to understand how we got where we are today, because it didn't happen overnight. So a lot of people fail to realize, but back in the 1950s, there was a deinstitutionalization of state mental health hospitals. And when they started doing that disinstitutionalization or that destabilization of these hospitals, what it did, it allowed people who were being discharged, they were being discharged without the assurance that they would receive appropriate medication and rehabilitation services necessary to live a successful life in their community. So what that did as a result is it left a population of individuals who had mental health issues and possibly substance use issues, either untreated, undertreated, or self-medicating. Here in Louisiana, we only have 2 state hospitals. That's Central Louisiana on the left, which is located in Pineville, and East Louisiana on the right, which is located in Jackson, Louisiana. So we had a bunch, and then this is what we were left with. And to sum that up, to give it perspective, is right now there is a 4 to 5 year wait period to get into the Central Louisiana state facility right now for long-term care. So when we take that information and we hone into East Baton Rouge Parish solely, we realize that over the last 10 years, we have seen a rise in the number of mental health cases and substance use cases, not only here in East Baton Rouge, statewide and nationally as well as a whole. But when we look at it, we say, okay, what contributed to East Baton Rouge Parish's rise. And there are a couple of things that stand out. One being the closure of Earl K. Long. For those who are not familiar with East Baton Rouge Parish, Earl K. Long was a charity hospital we had here in Baton Rouge. And Earl K. Long had within its facility what was called a mental health emergency room extension that saw about 2,000 people annually, and it provided mental health services. And what it did, it allowed law enforcement or first responders, if they came across someone who had a mental health challenge or substance use issue, they will be able to go to Earl K. Long to take them to be assessed. So again, when that facility closed in 2013 due to budget cuts, it left a void. So you had people going either to parish prison or they were going to your local emergency departments. In 2015, following Earl K. Long closure, the emergency department of the Baton Rouge General Mid-City campus closed. So you're taking that 2,000 population from Earl K. Long plus the combination of however many people were being treated at the Baton Rouge General Mid-City campus, and then you're leaving a void in our parish with people having nowhere to go, because you also in combination, you have to look at demographics and logistics. These hospitals were fairly close. They were in, the one in Mid-City was like in the middle of the parish. The one Earl K. Long was closer to the northern half of the parish. So when you close these two facilities, you left a void of services that can be provided for people who had logistics issues trying to get the help that they needed. So when you look at this number here, this right here is the information from the coroner's office for East Baton Rouge Parish. And in this information, it talks about the number of OPCs and CECs. And what OPC stands for is Order of Protective Custody. In order to get one of these, you have to go to the coroner's office and fill out an affidavit and explain to them that you've witnessed a particular person under 3 conditions. Either they are a danger to themselves, they are a danger to others, or they are gravely ill. And once they fill out this affidavit, it's given to a law enforcement individual, and they will go try to locate that person. And then they will bring them to an emergency department, now the Bruce Center for Hope, for them to get a psychiatric evaluation. That CEC stands for Coroner's Emergency Certificate. So you have to have 2 forms, 2 evaluations in order for somebody to be held involuntarily. So you have to have a CEC from the coroner's office, and you also have to have a PEC from the physician. So for example, if you were to take someone, if someone was to do an OPC on you, Order of Protective Custody, the law enforcement officer picks that person up, bring them to the emergency room, then the physician on call or the physician in the emergency room will do a PEC, and then they will call for the coroner's office to do a CEC. That's how someone is involuntarily committed if they both sign off on it. Both individuals have to sign off on it, the coroners and the physician on call, or the physician that's seeing that individual. And the reason why I wanted to show this particular graph is because this is mental health cases. And if you look at 2011, when the emergency room extension for Earl K. Long was open and the Mid-City campus at the Baton Rouge General was open, our numbers were relatively low. We had 473 OPCs issued, 3,152 CECs that were issued out of the coroner's office. And when you fast forward to May of 2021, we've already exceeded those numbers for a whole year in 2011. So that lets you know that we're on track to either equal 2020 or surpass it. Right now, we're looking at 3,214 CECs and 526 OPCs, and that's from January to May. So we still haven't tracked the numbers for June or July, and we still have several months to go by the end of the year. This next slide talks about the number of fatal and non-fatal overdoses that we have here in East Baton Rouge Parish. And by looking at the graph, you can see that Baton Rouge East Baton Rouge Parish is on track to surpass the 2020 record-breaking numbers of 242 fatal overdoses and 1,014 non-fatal. Right now, this chart represents to the end of June. So right now, as of June 30th, there were 115 fatal overdoses and 718 non-fatal overdoses. So we talk about these things and we look at these things and we wonder, you know, as a community, what are we supposed to do? And at a parish level, we kind of went back to say, okay, we realized that the mental health community, the substance use community is suffering, and we need to figure out a way to do that. And so therefore that birthed the Bridge Center for Hope out of the Baton Rouge Area Foundation. They put together several key stakeholders. You had community advocates, you had the Justice League, Justice Departments, you also had behavioral health specialists that came together and formed the Bridge Center for Hope, the nonprofit. And what that nonprofit did is they tried to figure out a way to bring back a mental health facility here in East Baton Rouge Parish that will be able to treat the most vulnerable, the ones who, you know, some people consider left behind. And in 2016, they went and tried to solicit a parish tax to be able to fund this facility, but it didn't pass. So after extensive research and getting with consultants in 2017 to educate not only themselves, but also to educate East Baton Rouge Parish residents as to why a mental health facility is needed, they went back and put the parish tax back on the ballot in 2018, where it passed by 64%. So more than half of the residents agreed to tax themselves to be able to fund a facility that will be able to provide mental health services for its residents. So we look at what's the purpose of the Bridge Center for Hope. And really it is to provide 24-hour, 7 days a week, comprehensive crisis care for voluntary and involuntary individuals in East Baton Rouge Parish that are 18 years and older. And it also provides crisis services to individuals who are suffering from a mental illness or a substance use challenge, regardless of income or insurance, meaning that parish tax that the Bridge Center passed. If someone is having a mental health crisis and they come to the Bridge Center and they don't have insurance, we operate under RI's no wrong door policy. So we don't tell them no, we still provide services. If they don't have insurance, we still provide services. The Bridge Center for Hope covers the indigent population. So there's no reason for anyone in East Baton Rouge Parish to say that they couldn't receive services at the Bridge Center for Hope because they didn't have income or insurance. That's not a barrier for us here at the facility. We take those barriers away so that you can get the proper care, so you're not worrying about trying to receive a bill, because you will never receive a bill from the Bridge Center for Hope. The only criteria that we really have is to be 18 years and older. And we try to stick with East Baton Rouge Parish residents because it is a parish tax. However, we're not going to turn people away if they're in crisis. So we did get a grant to be able to fund some of the individuals that are out of our parish. And then lastly, which is the Bridge Center motto, is to provide pathways to treatment for people who are experiencing a behavioral health issue and link them to providers to create integrated continuum of care from prevention and to rehabilitation. So what does that mean? It means that individuals who are entering the Bridge Center for Hope for treatment, regardless if it's for a mental health crisis or for a substance use crisis, what we wanted to do was make sure that when they left the facility, they were given an outpatient appointment with a provider. So we're connecting them to outpatient providers so that they can continue in their care. And that was one of the things that was attractive to the Bridge Center for Hope Board of Directors when RI was selected as the service provider, was that they had all of this already in place, and they have been practicing these mottos for several years before we came on the board. So it was kind of like a no-brainer for us. Even though we did solicit proposals throughout the country, they were the ones who ultimately won out. So as Lysha had alluded earlier, you know, it was the Bridge Center for Hope, the nonprofit, and we did that solicitation proposals back in 2019, and RI International was selected, and that's how we're here together today. They provide the services for the facility. So what I wanted to do is show you guys a quick little 2-minute video. It's just an overview of what the Bridge Center for Hope is, what it looks like, and what is offered in the facility. And then there are a few slides that go more in depth as to what the facility contains and how each unit is operated. And Lysha will be able to explain those to you a little bit more in depth in a minute.
When we took a deep look at our community, we saw that thousands of people living with mental health and substance use challenges were not getting the care they deserve. We saw a great opportunity to better support people in crisis. For many years, people in crisis were being dropped off at already overcrowded emergency rooms and local jails, which made our community say, there has to be a better way. Introducing the Bridge Center for Hope, a new state-of-the-art crisis receiving center, a place where people experiencing mental health and substance use challenges can get the help they deserve. The Bridge Center for Hope utilizes the Crisis Now model, an evidence-based approach to crisis care that provides immediate help for those in distress, prevents suicide, reduces cost, and the strain on emergency rooms and prisons. We created a safety net to stabilize people with mental health and/or substance use challenges by providing immediate crisis services and connecting them with service providers and community resources. Services include 23-hour observation unit, 16-bed short-term psychiatric unit, 16-bed medical detoxification unit, 16-bed center-based respite unit, care management team, and a mobile response team. The Bridge Center for Hope, in partnership with RI International, provides individualized treatment and resources that will help East Baton Rouge Parish residents, 18 and older, overcome their mental health and substance use challenges and lead healthy, happy, and fulfilling lives. Learn more about the Bridge Center for Hope at brbridge.org.
So this right here is the actual facility. It's located at 3455 Florida Boulevard, which is directly across the street from the Baton Rouge General Mid-City campus. And I want to say this, the Baton Rouge General recently opened up their emergency department last year in 2020 to have full services. Keep in mind that they were closed from 2015 and they reopened again 5 years later, which is unheard of and unprecedented. And we're so thankful and grateful that that community asset came back to East Baton Rouge Parish because it was greatly needed. And the fact that they're directly across the street from the Bridge Center for Hope is also a huge plus for us as well. So the next slide is the overview of the actual facility. Each one of these colors represents a different unit, and Lysha will go into each unit explaining how those services are provided and who provides those services.
Yes, absolutely. So I'm looking at the time, so I'm not going to stay too long on it because I do want to get you guys questions. So this is our 23-hour stabilization unit. So this is our entry point for any individual that come in our facility, either voluntary or involuntary. They will start on this unit. So on this unit, we have 16 recliner chairs, and it's set up just for optimal observation, because within that first 23 hours is when we decide or think through what's the best course of action for that individual. So on this unit, we have psychiatrists, psychiatric nurse practitioners, RNs, LMHP, so LCSWs or LPCs, certified peer support specialists, and then also milieu specialists. So when individuals come in, they receive a clinical assessment by an LMHP, a nursing assessment, a psychiatric evaluation. They also have individual and group therapy, and then we also really focus on peer engagement. So after that first 23 hours and those assessments happen, like I said, we really decide what happens with that individual. Some people are able to be stabilized, and then we discharge them back to the community with an appropriate discharge plan with appointments and such. But if they need a longer term stay, longer term for us means 3 to 7 days. So if they need a longer term stay, they can go to our short-term psychiatric unit if they have a psychiatric diagnosis. Over there, we have 16 beds. So we have 8 double occupancy rooms. And it really focused on additional stabilization for that individual and med management, making sure that they're on the medications that they need to be on. And over there, we have the same type of staff, psychiatrists, nurse practitioners, nurses, and such. And they have a really robust daily schedule on this unit. They have about 4 to 5 groups a day, daily treatment sessions with the nurse practitioners and the licensed mental health professional. And then they also do peer engagement. We do art therapy, music therapy on this unit as well. They can also go to our 16-bed medical detoxification unit. So over here, we have 7 double occupancy rooms and 2 single occupancy rooms. So it's designed for individuals needing detoxification from some type of substance. We have the same type of staff over here, except for on this unit, we did have to add an addictionologist that specializes in addiction medicine. They have a bit of a different schedule, meaning treatment schedule, but they have the same amount of groups per day, daily treatment sessions as well, and individual and group therapy. We typically try to have an outside space, but because of where the facility is located, we did have to become creative and figured out a way for the individuals to still be able to go outside. So we built a patio on the side of this unit, which they really enjoy going out and just getting some fresh air. Go ahead. We also have a 16-bed center-based respite unit. So our respite unit is our lowest level of care at the facility. We, on this unit, individuals will go over there so they have some type of respite away from their living situation so they don't go into crisis. We also would use this unit as the middle point between the individuals discharging from the facility and their next step. So if they're going to like a sober living environment and their bed is not ready for about 3 days or so, we want to make sure that they remain safe. So we would transfer them to our respite unit so they can, so it's not a gap in their care. Our last 2 services are, we have a care management team. So our care management team is a 2-person team, so an LMHP and a certified peer, and they function as like a discharge planning team. So they make sure that individuals have good discharge plans when they leave, make sure that everyone discharges with an outpatient appointment, either mental health or substance use, and also a primary care appointment. And they're also able to follow individuals in the community for up to 30 days. So we can do a warm handoff from the staff here at the facility and to the staff, whatever their next step is, whatever that appointment is. We want to make sure that we do a warm handoff. And then our last service is our mobile response team. So it's a 2-person team as well. And then we will respond to, from 911 dispatch, they will dispatch us with a crisis in the community, and then we will respond to that crisis. So we will try to stabilize them in the community, but if we can't, the team would go ahead and transport them to the facility.
So you've kind of heard about how the best practices work and then how those best practices work here at the Bridge Center for Hope. And a lot of people want to know, how are we doing? And so we opened on February the 11th of this year. And so far we've been open a little bit over 159 days. I think when I did this presentation, it was 159, so now it's about 160, 161. Of those days, from February the 11th to June 30th, we've seen or admitted 829 guests. 51% of those individuals receive mental health services, the other, and 49% receive substance use. And then there's a combination in there, but that's not identified. 58% of those guests came to the facility independently, meaning that they came on their own or they came with a family member, but they were not escorted by first responders. 48% were escorted by first responders, and that could have been law enforcement or that could have been EMS. And then for East Baton Rouge Parish, our Baton Rouge Police Department accounts for 66% of the first responder escorts and followed by 21% EMS. When Lysha spoke earlier with the Crisis Now model, where they were speaking about trying to get first responders in and out between 5 to 7 minutes, the Bridge Center has actually exceeded that time by 3 minutes and 71 seconds. That's our average handle time to get first responders in and out of the facility. So if you have any questions, this is our contact information. I thought my next slide was going to be a Q&A, but I guess it's not, but I'll go back to this one in a second. There we go.
Okay, you guys are ready for questions?
Yes.
Okay. So there is a question in the chat. One was already answered. Do children have access to the crisis services? So they have to be 18 years or older, right?
Yes.
And the next question is, will there be appropriate accommodations for developmentally disabled, particularly if they're severe?
Yes, we do. Yes, we do. So we handle those cases on a case-by-case basis. And any individual that come in, we try to connect with the resources that they would have already had in the community. And if they don't have those resources when they come in, we will work together. We do a treatment team meeting to make sure that we connect internally, and then also lean on those community resources to make sure that we are able to provide good whole person care. So yes, we will make those accommodations.
And this is Bambi. I think to get to the heart of what the intent of those questions is, because I know this very well, is that we don't have that integrated type of care for our people with developmental disabilities and behavioral health. So do you guys have the expertise and I guess the resources or maybe some knowledge that many of us in the community don't have on how to get that integrated type of care for people with developmental disabilities and behavioral health needs?
Yes, so I will not say that we are the subject matter experts in developmental disabilities. And so we do work on making sure that we continue to develop that, but I can't say that we are the experts in that area. But if an individual comes in with developmental disability and behavioral health, we will work together to try to find those resources in the community as well.
Okay, the next question from YouTube. No, I'm sorry, before YouTube. What number does a person in crisis call?
Oh, that's easy. Well, that number for whoever wants it is area code 225-256-6604. That's the number to the facility. But I also want to stress that if someone is in the middle of a crisis or they're having suicidal ideations, you still also have a resource with United Way where 211. So you can still dial 211 and do option 3, and then that will give you to a crisis person as well. And then also 911 is always accessible.
Okay.
And if you are in crisis, you don't have, if you're in East Baton Rouge Parish, you don't have to call the facility first. You can just show up to the facility. That would be the best course of action.
Okay. Do you do any training and outreach with law enforcement agencies to help officers identify someone in a mental health crisis and then call the crisis team ASAP?
Yes, we do. So we participate in the CIT, so crisis intervention training for Baton Rouge Police Department. And then we also provide any education to any law enforcement entity about mental health, how to identify those individuals. And then that's another reason why we try to, as a company, we try to remove all the barriers for law enforcement because they are not the experts in that area. So if they come in contact with an individual, we just want them to bring them to us and we will figure it out. But we do also, like I said, we do provide education to them and the community as well.
Okay. Will they have centers for children and children with disabilities?
So that's something that the board of the Bridge Center for Hope has been looking into, is providing services for individuals under the age of 18. We're not there just yet because we just opened this facility. So in the coming years, we will revisit that topic, but that is something that we really want to get into because we know that mental health doesn't start at onset at 18. So we want to be able to provide some type of services for our adolescent population.
Okay. What is the staff to patient ratio?
So typically we have about 8 staff members to 16 guests.
Okay.
On each unit.
Okay. It's to 16. Okay. It's like 1 to 2?
Yeah.
I mean,
except for our respite unit. Our respite, like I said, our respite unit is our lowest level of care. And so the individual over there are pretty stable. They have to be independent, know how to take their own medications and such. And so over there, we have three staff members to 16.
Okay. Do you do family counseling sessions? And if so, how many?
We do have the capacity to do family counseling sessions. if the individual requests it. Because if the individual comes in and they're struggling with their family or natural supports, and they feel like they need someone to mitigate or manage that conversation, we can do family sessions. Yes, it is on a case-by-case basis.
Okay. Can families helping families refer families to your center by providing them with your information, or is there a referral process?
No, we don't have a referral process. No. So like I said, I know it sounds like too easy, but anybody can come at any time. We don't have a formal referral process. You can call the facility and talk to a shift supervisor if you wanted to provide us with like collateral information, but you don't have to call us first.
Okay.
Excuse me, this is Bambi. Just want to remind the interpreters to please don't spotlight when we don't have a presentation showing for recording purposes.
Okay. The questions are rolling in, but we have a few more minutes. So do you do any, let me see if I could change the view on my screen. Okay. Do you do any training for teachers and school administrators? Some of our students are 18 and older.
Do we do currently? No, we don't. Currently, no, we don't. But that's definitely something that I'm sure Charlotte and I will have a conversation about to make sure that we get out there and have those conversations with them. I know, COVID kind of slowed us down because when when we started, we were full speed ahead, and then COVID kind of slowed us down. So we're trying to get that momentum back up, but we're definitely going to go out there and have those conversations with them.
Okay. What is the status of developing a 911 for suicide crisis services in Louisiana?
Yeah, so 988 is rolling out right in 2022. But I think I don't have the status for Louisiana. That's a way bigger question than me. That's a state rollout plan that I'm sure is going to come from LDH. So 988 is coming next year, but the states have to have their plans set on a governmental level.
Yeah, the last thing that I heard in a meeting was it was scheduled to roll out in July of 2022. Now that's yet to be seen, but that was just the last information that we received at the time. But that's don't hold me or us accountable for that particular time frame.
Yes, everyone has to come up with their own plan.
Okay. And I had a question. You talked about the peer professionals.
Mm-hmm.
And so I like the peer first, peer last. Who would be considered a peer? How do they qualify to be a peer?
So a certified peer is anyone that have lived experience. So they would have had to gone through some type of mental health challenge in the past or a substance use challenge, and they've been clean for a little while. They go through, we provide a 2-week certification course, talking through with them how to tell their story, how to connect with individuals, how to have an empathic approach. And what we found is that, I'm a licensed clinician, and I really rely on the peers to have that conversation with individuals because I've never gone through a substance use challenge. So I can't connect in that manner. So that's why we do a peer first, peer last. So they get to build that connection, then they go through with the clinical stuff and then continue to do the peer engagement. And then also when they leave, they talk to a peer again to further solidify that, if I could have done it, I did it, this is what I've gone through. So I'm sending you out now and I'm trying to give you all the skills that I learned. So you can also get there.
And to answer that question on a state level, the state does provide peer certification training classes, and it's an actual model that's based off of RI International.
Yes, our peer model is the one that the state of Louisiana uses to certify their peer support specialists.
Yeah. So if they go to LDH's website, they'll tell them they have classes if they're not here in East Baton Rouge Parish or working for RI.
Very good. And so the criteria is there too, like how long you would have had to been, I guess,
recovery. Yes, in recovery. Yes, absolutely. Mm-hmm.
All right, we'll take one last question. And this is from the YouTube live stream. Do you have a criteria or a certain level patient that you would not deem as a patient for your facility?
No. So like I said, the biggest criteria for us is you have to be 18 and over. That's the biggest thing. But when individuals come in, like I said, we just have to make sure that they're medically stable to be at this facility. So we try to say our facility is like infirmary level. So we make sure we can deal with like high blood pressure, diabetes, and stuff like that. But anything that's like super serious, we will have to get some further assistance from a hospital setting of some sort. And then they will come back to us. But yes, we don't have any like a major criteria or anything like that.
Okay, I guess it's convenient that Baton Rouge General is across the street, maybe?
It is, yep, it's convenient. We work with them, and then we also work with the Our Lady of the Lake as well. We try to utilize, we actually utilize the both of them.
Okay. Charlotte was gonna say something?
No, I'm just smiling.
So
I'm
Bambi,
the only criteria that they probably wouldn't take is something if I walked in there, like, no. So.
Bambi has a question, so she'll get the last word.
Yeah, so my question is, seems like a great model and great that East Baton Rouge residents saw the need and passed this tax, but we have many people who are listening and watching, or people who are advocates and kind of system change advocates. And so what would you suggest for people who live outside of East Baton Rouge if they want to see this in their community? And I know I'm asking you a question that's probably its own presentation, its own conference, but can y'all give any words?
Well, you can reach out to Lysha, and you can reach out to myself and Lysha. We'll be more than happy to talk to any area that is considering to be able to utilize something similar to the Bruce Center for Hope. We know that for us, if you go to our website, there is a link that talks about the reports that we utilize to be able to fund this facility. There was an extensive year-long research that we did with the Emergent Method that talks about how to go about funding and what we needed. And based off of that report and that consultation, that's how we was led to the model that we wanted to use, which we didn't know existed until we realized RI was already doing it. So if you go to our webpage, our website, brbridge.org, you can find all of the resource material that we utilize to be able to start this facility up. And then I'm sure RI has some additional information on their website as well.
Yes, and I think just the short of that is just in your community, just talk to anybody that would listen, talk to your legislatures in your area, and just have the conversation about if you really feel that a facility like this one is needed in your area, just talk to the powers that be, and have these conversations about the need. And, we're already doing it in East Baton Rouge Parish, but we know that it's needed around the state.
And with being in Louisiana, just don't give up, because we know we get told no first a lot. So you just keep going, because we were told no first when we tried to do this tax passage, and we just said, okay, let's check and adjust, and we went back. So be persistent as well.
All right, well, thank you all so much. This was some really good information. Thank you for the resources to be able to look at the information on your website. I'm not sure if your PowerPoint will be available for others to be able to look at. If it is, if you want to send it to me, we can send it out to others. Otherwise, they can just go to the website and get the information there, right?
Yes. Yes.
Thank you guys so much. We really appreciate you agreeing to do this. This is some really good information.
Thank you for having us.
Thank you guys for having us. All right. Have a good day.
Bye.
Bye-bye.